This lecture will be a review of the human immunodeficiency virus, HIV. HIV causes the infected individual to be susceptible to infections that would normally be controlled by our immune system. The term HIV is used interchangeably with HIV infection. Historically, in North America, HIV has been more prevalent amongst homosexual men. However, increasing numbers of new HIV infections are occurring in women, people of color, people who live in poverty, and young adults. HIV transmission occurs through sexual intercourse with an infected partner, exposure to HIV-infected blood, and perinatal transmission during pregnancy, at delivery, or through breastfeeding. The virus cannot be transmitted through such actions as hugging, shaking hands, or sharing eating utensils. It is also not spread by tears, saliva, urine, or any other body secretion. Sexual activity involves contact with semen, secretions, and our blood, all of which have lymphocytes that may contain HIV. Sexual activities that cause trauma to local tissue can increase the risk of transmission. Genital lesions from other sexually transmitted infections, such as herpes or syphilis, significantly increase the likelihood of transmission. Needles, syringes, and other equipment may be contaminated with HIV or other bloodborne organisms. Sharing this equipment can result in disease transmission. Routine screening of blood donors to identify at-risk individuals and testing donated blood for the presence of HIV has dramatically improved the safety of the nation's blood supply. The risk of infection after a needle stick exposure to HIV-infected blood is about 0.3% to 0.4%. The risk is higher if the exposure involves blood from a patient with a high level of circulating HIV, a deep wound, a needle with a hollow bore and visible blood, or a device used for venous or arterial access. Splash exposures of blood on skin with an open lesion present some risk, but it is much lower than from a puncture wound. Healthcare workers have a low risk of acquiring HIV at work even after a needle stick injury. Perinatal transmission can occur from an HIV-infected mother to their infant. Fortunately, the risk of transmission can be reduced to less than 2% in settings where pregnant women are routinely tested for HIV infection. If found to be infected, the mother is treated with antiretroviral therapy, which is a combination of medication used to control and suppress HIV replication. HIV is a ribonucleic acid virus, called a retrovirus because they replicate in a backward manner going from RNA to DNA. The CD4 T cell is the target cell for HIV. It's a type of lymphocyte. The HIV binds to the cell through fusion. HIV is surrounded by an envelope made up of proteins including GP120. The HIV virus contains a core of viral RNA and proteins. Like all viruses, HIV cannot replicate unless it is inside a living cell. Once HIV is attached and fused with specific protein receptors on the outside of the CD4 cell, HIV RNA enters the cell. This triggers the release of reverse transcriptionase, an enzyme that transforms HIV RNA into a single strand of DNA. This strand copies itself, becoming double-stranded viral DNA. Another enzyme called integrase allows the newly formed double-stranded DNA to integrate itself into the host's genetic structure. Protease, another enzyme found in the replication process, cleaves the newly formed strands of HIV genetic material into smaller pieces. New HIV virons are then formed and released. The CD4 T cell is then destroyed after the HIV virons are released. HIV destroys about 1 billion CD4 T cells every day. For many years, the body can produce a new CD4 T cell to replace the destroyed cells. However, over time, the ability of HIV to destroy CD4 T cells exceeds the body's ability to replace the cells. The decline in the CD4 T cell count impairs immune function. A point is eventually reached where so many CD4 T cells have been destroyed that not enough are left to regulate immune responses. This allows opportunistic diseases such as infections and cancers to develop. Opportunistic diseases are the main cause of disease, disability, and death in patients with HIV infection. This displays the typical course of untreated HIV infection. It is important to remember that disease progression is highly individualized. Treatment can significantly alter this pattern, and an individual's prognosis is unpredictable. The information depicted in this figure represents data from large groups of people and should not be used to predict an individual's prognosis. Some people also develop neurological complications such as septic meningitis, peripheral neuropathy, facial palsy, or Guillain-Barré syndrome. During this time, a high viral load, the amount of HIV circulating in the blood, is noted, and CD4 T cell counts fall temporarily, but quickly return to baseline or near baseline levels. Many people, including healthcare providers, mistake acute HIV symptoms for a bad case of the flu. Individuals are most infectious during the acute infection stage because of the high amounts of circulating HIV. Because most of the symptoms during early infection are vague and nonspecific for HIV, people may not be aware that they are infected. Risky behaviors become a public health problem because infected individuals can transmit HIV to others even though they have no symptoms. Personal health is also affected because people who do not know that they are infected have little reason to seek treatment and are less likely to make behavior changes that can improve the quality and length of their lives. As the viral load increases, symptoms such as persistent fever, frequent night sweats, chronic diarrhea, recurrent headaches, and severe fatigue may develop. One of the most common infections associated with symptomatic infection is oropharyngeal candidiasis, or thrush. Candida organisms rarely cause problems in healthy adults, but are more common in HIV-infected people. Other infections that can occur at this time include shingles, which are caused by the varicella-zoster virus, persistent vaginal yeast infections, outbreaks of oral or genital herpes, and bacterial infections. Malignant vascular lesions, such as Kaposi sarcoma lesions, can appear anywhere on the skin surface or on internal organs. Kaposi sarcoma is caused by human herpes virus 8. Lesions vary in size from pinpoint to very large and may appear in a variety of shades. Oral hairy leukoplakia, an Epstein-Barr virus infection that causes painless, white raised lesions on the lateral aspect of the tongue, can occur at this phase of the infection, and it is another indicator of disease progression. Organisms that do not cause severe disease in people with functioning immune systems can cause debilitating, disseminated, and life-threatening infections during this stage. Several opportunistic diseases may occur at the same time, compounding the difficulties of diagnosis and treatment. Advances in HIV treatment have decreased the occurrence of opportunistic diseases. Opportunistic diseases generally do not occur in the presence of a functioning immune system. Pneumocystis jirovecii is a type of pneumonia that can appear as an opportunistic disease associated with HIV infection. Combination antibody and antigen tests decrease the window period to within 3 weeks following infection. As the disease progresses, the number of CD4 T cells usually decrease. The normal range for CD4 C cells is 800 to 1200 cells. Viral loads are reported as real numbers. The goal of treatment is to suppress the viral load to the lowest level possible, which is below the level of detection on a commercial assay. This is often referred to as undetectable. Undetectable does not mean that the virus has been eliminated from the body or that the individual can no longer transmit HIV to others. Rather, it refers to the fact that the amount of circulating HIV in the blood is below the level of detection of the test. Decreased white blood cell counts, especially below normal levels of lymphocytes, and neutrophils are often seen. Low platelet counts, or thrombocytopenia, may be caused by HIV, antiplatelet antibodies, or drug therapy. Anemia is associated with the chronic disease process and with adverse effects of ART. Altered liver function caused by HIV infection, drug therapy, or co-infection with the hepatitis virus is common. Early identification of co-infection with hepatitis B or hepatitis C is extremely important because these infections have a more serious course in patients with HIV, may ultimately limit options for ART, and can cause liver-related morbidity and mortality. Resistance tests can determine if a patient's HIV is resistant to drugs used for ART. Genotype and phenotype assays are similar to culture and sensitivity testing used for antibiotic selection. Interprofessional care of the HIV-infected patient focuses on monitoring HIV disease progression and immune function, initiating and monitoring antiretroviral therapy or ART, preventing the development of opportunistic infections, detecting and treating opportunistic diseases, managing symptoms, preventing or decreasing complications of treatment, and preventing further transmission of HIV. To accomplish these goals, ongoing assessment, clinician-patient interactions, and patient teaching with support are required. Perform complete history and physical examination. These findings will determine the patient's needs. This is also a good time to ensure that case reports required by the state health department have been completed. Determine the needs for referrals. Remember that a newly diagnosed patient may not be able to retain or understand information. Be prepared to repeat and clarify information over the course of several months. Recommendations for starting therapy in the chronically infected patient are summarized in Table 1413 in your book. HIV cannot be cured, but ART can delay disease progression by decreasing viral replication. When taken consistently and correctly, ART can reduce viral loads by 90 to 99%, which makes adherence to treatment regimens extremely important. The major advantage of using drugs from different classes is that combination therapy can inhibit viral replication in several different ways, making it more difficult for the virus to recover and decreasing the likelihood of drug resistance. A major problem with most drugs used in art is that resistance develops rapidly when they are used alone and taken in inadequate doses. Thus, combination of 3 or more should be used. Many art drugs have dangerous and potentially lethal interactions. Be sure to ask patients about prescribed and over-the-counter drugs, as well as herbal products and supplements. Management of HIV is complicated by the many opportunistic diseases that can develop as the immune system deteriorates. Prevention is the preferred approach to opportunistic diseases. A number of opportunistic diseases associated with HIV can be delayed or prevented with adequate art, vaccines for Hep B, influenza, and pneumococcal, and disease-specific prevention measures. Although it is usually not possible to eradicate opportunistic diseases once they occur, prophylactic medications can significantly decrease morbidity and mortality rates. Advances in the prevention, diagnosis, and treatment of opportunistic diseases have contributed significantly to increased life expectancy. Pre-exposure prophylaxis should be used in conjunction with other proven prevention interventions such as condoms, risk reduction counseling, and regular HIV testing. Truvada is used to reduce the risk of HIV infection in uninfected individuals who are at significant risk of acquiring HIV. Truvada is also currently used in combination with other antiretroviral agents for the treatment of HIV-infected people. Since HIV infection can be prevented, nursing care for individuals not known to be infected with HIV should focus on preventing disease transmission. The first step is to assess the patient's individual risk behaviors, knowledge, and skills. Do not make assumptions about people or their behavior. Assess for risky behaviors on a regular basis because things can change. Ask if they have ever been sexually active with someone known to have HIV. These questions provide the minimum information needed to initiate a risk assessment. Follow up a positive response to any of these questions by an in-depth exploration of issues related to the identified risk. Based on the assessment, nursing interventions can then encourage the patient to adopt safer, healthier, and less risky behaviors, particularly in regard to sexual intercourse, drug use, perinatal transmission, and work issues. Specific assessments are needed for an individual who has been diagnosed with HIV infection. Subjective and objective data should be obtained. Early recognition and treatment can slow the progression of HIV infection and prevent new infections. A complete history and thorough systems review can help identify and address problems in a timely manner. Nursing interventions can help the patient to adhere to drug regimens, promote a healthy lifestyle that includes avoiding exposure to other STDs and bloodborne diseases, protect others from HIV, maintain or develop healthy and supportive relationships, maintain activities and productivity and quality of life, explore spiritual issues, come to terms with issues related to disease, disability, and even death, and cope with symptoms caused by HIV and its symptoms. The complexity of HIV disease is related to its chronic nature. As with most chronic and infectious diseases, primary prevention and health promotion are the most effective healthcare strategies. Even with recent successes in HIV treatment, prevention remains a critical component to control the epidemic. Health promotion encourages early detection of the disease so that if primary prevention has failed, early interventions can be initiated. Nursing interventions are based on and tailored to patients' needs and early stage of HIV disease and can be instrumental in improving the quality and quantity of the patient's life. Care plans are individualized and change as new treatment protocols are developed and or as HIV disease progresses. The goal is to develop safer, healthier, and less risky behaviors. These techniques can be divided into safe activities and risk-reducing activities. You need to be prepared to discuss sensitive topics including sexuality and drug use. Suggest a wide variety of activities to reduce the risk of HIV infection so individuals can choose methods that best fit their needs, circumstances, and individual life patterns. Safe sexual activities eliminate the risk of exposure to HIV in semen and vaginal secretions. Abstinence is the most effective strategy. There are safe options for those who cannot or do not wish to abstain. Risk-reducing sexual activities decrease the risk of contact with HIV through the use of barriers. Barriers should be used when a partner whose HIV status is not known or who is known to have HIV. Drug use, including alcohol and tobacco, can cause immunosuppression, poor nutrition, and a host of psychosocial problems. However, drug use does not cause HIV infection. The major risk for HIV related to using drugs involves sharing equipment or having unsafe sexual experiences. Injecting equipment includes needles, syringes, cookers used to mix the drug, and rinse water. Equipment used to snort or smoke pipes can also be contaminated with blood and should not be shared. Some communities have needle and syringe exchange programs that provide sterile equipment in exchange for used equipment. Studies show drug use does not increase, rate of HIV and other bloodborne infections are controlled, and an overall cost benefit results in these communities. Cleaning equipment before use can also reduce risk by decreasing the chance of blood contact. Providing support for patients with substance use and referring individuals to professionals who can assist patients manage the psychological aspects of substance use is important. Other self-help programs, such as AAA or Narcotics Anonymous, may also be beneficial. Women need to have information about family planning methods, HIV, HIV antibody testing, and ART if infected. Pregnant HIV-infected women need information on how to maintain their pregnancy, using ART to decrease the risk of transmission, and possible abortion options. If HIV-infected pregnant women are appropriately treated during pregnancy, the rate of perinatal transmission can be decreased from 25 to less than 2%. ART has significantly decreased the risk for infant born to HIV-infected women, and more of these women are now becoming mothers. The risk of infection from occupational exposure to HIV is small but real. Should the nurse be exposed to HIV-infected fluids, post-exposure prophylaxis with combination ART can significantly decrease the risk of infection. The goal is to normalize the test, decrease the stigma related to HIV testing, find hidden cases, get infected individuals into care, and prevent new cases of infection. The nursing assessment in HIV disease should focus on early detection of symptoms, opportunistic diseases, and psychosocial problems. They will be confronted with complex treatment decisions, feelings of loss, anger, depression, and grief, social isolation, alter concepts of this physical, social, emotional, and creative self, the possibility of death, and our thoughts of suicide. Patients and their family members, friends, and caregivers must also deal with associated social stigma and discrimination. These factors can contribute to problems with adherence to treatment, a dangerous situation because of the high risk of developing drug resistance. Interventions you may provide include teaching about advantages and disadvantages of new treatments, dangers of poor adherence to therapeutic regimes, how and when to take each drug interactions to avoid, and side effects that must be reported to the healthcare provider. Clinical guidelines provide information on initial drug regimens. However, one of the most important considerations for initiating therapy is patient readiness for treatment. Guidelines on when and how to initiate ART are based on the degree of immune suppression. Issues to consider when selecting an initial drug regimen includes the ability of the patient's HIV to resist specific drugs, potential medication side effects, existing comorbidities, and dosing schedules. This is a critical decision because the first treatment regimen is generally the patient's best chance for success. The difficulty of adhering consistently is probably clear to anyone who has tried to take a 10-day course of antibiotics. Patients in treatment for HIV infection must take at least one pill a day, but sometimes many more, and they must take these pills every day for the rest of their lives, even when uncomfortable from side effects. Missing even a few doses can lead to drug resistance. Strategies to improve adherence to ART include simplify regimens, use reminders, and elicit support. Supporting a healthy immune system can help delay HIV disease progression, whether or not the patient chooses to take ART or not. Interventions include nutritional support to maintain lean body mass and ensure appropriate levels of vitamins and micronutrients, moderation or elimination of alcohol, tobacco, and drug use, keeping up to date with vaccines, getting adequate rest and exercise, reducing stress, avoiding exposure to new infectious agents, accessing counseling, getting involved in support groups and community activities, and developing a consistent relationship with healthcare providers, including attendance to regularly scheduled appointments. Teach patients to recognize symptoms that may indicate disease progression or opportunistic infections. Chronic diseases are characterized by acute exacerbations. Nursing care becomes more complex as the patient's immune system deteriorates and new problems arise to compound existing difficulties. The best way to prevent opportunistic disease is to assure that the patient is adhering to their effective ART regimen and taking prophylactic medications for opportunistic infections. Providing supportive care specific to the opportunistic disease, should it occur, is important nursing care. Although HIV-infected patients share problems experienced by all individuals with chronic diseases, these problems are exacerbated by negative social attitudes and beliefs surrounding HIV. Behaviors may be viewed as immoral, illegal or reflect a lack of personal control. Even though illegal according to the ADA, fear surrounding the transmittable nature of the disease can lead to pervasive stigma and discrimination. Physical problems related to HIV and its treatments can interrupt the patient's ability to maintain a desired lifestyle. Nursing interventions are similar to those for patients who do not have HIV. Some HIV-infected patients, especially those who have been infected and on ART for a long time, may develop a set of metabolic disorders. Hyperlipidemia includes elevated triglycerides, low-density lipoproteins, and decreased high-density lipoproteins. Lipid abnormalities are generally treated with lipid-lowering drugs, dietary changes, and exercise. Insulin resistance is treated with hypoglycemic drugs and weight loss. Bone diseases involving osteoporosis, osteopenia, and avascular osteonecrosis. Bone disease may be improved with exercise, weight-bearing activities, dietary changes, calcium, and vitamin D supplements. It's not clear why these disorders develop, but is possible from a combination of factors including long-term infection with HIV, side effects of ART, genetic predisposition, and chronic stress. Lipodystrophy is changes in body shape caused by a redistribution of fat in the abdomen, upper back, and breast, along with fat loss in the arms, leg, and face. Management of these metabolic disorders focuses on early detection, symptom management, and helping patients cope with emerging problems and change treatment regimes, especially to avoid potentially fatal complications. A frequent first intervention is to change the ART medication because some drugs are more often associated with these disorders. Despite new developments in the treatment of HIV infection, many patients eventually experience disease progression, disability, and death. Sometimes treatments do not work for the patient. Sometimes the patient's HIV becomes resistant to all available drug therapies. In other cases, a patient may make a decision to forego further treatment, allowing the disease to progress towards death. The number of persons over age 60 living with HIV is anticipated to grow. As a nurse, you must need to be aware of the special health concerns of the HIV-infected older person. They are susceptible to the same diseases, heart cancer, diabetes, bone disease, arthritis, but may experience them at an earlier age. They also may be at higher risk of comorbidities due to the effects of the medications used to treat HIV. Polypharmacy is a concern because the multiple medications older adults may have to take could have interactions or be potentiated by HIV medications. It may be difficult for the older adult to get appropriate health care and support if they are ashamed and hesitant to tell anyone they have HIV. As a nurse, you need to recognize that HIV is a chronic disease that will affect an increasing number of older adults, and you must be prepared to help the older person who is living with HIV infection.